Our first presenter is Professor Rashida Ferrand, who is a clinician working in London who has extensive experience with HIV and has a PhD in epidemiology from the London School. She is going to be telling us about what's new in sexually transmitted infections and HIV in 2020. Over to you, Rashida.
Thank you for the opportunity to give a talk on what's new in sexually transmitted infections. It's difficult to do justice to such a large topic in 15 minutes, but I hope to highlight some of the recent developments in sexually transmitted infections in the next 15 minutes. There are more than 30 pathogens that are transmissible during sex, and most diseases related to sexual transmission are from the pathogens listed. While we have made huge strides in controlling and managing the HIV epidemic, the picture for other STIs is somewhat more bleak. The numbers tell the story. In 2016, there were 376 million cases of curable STIs, namely chlamydia, gonorrhea, trichomoniasis, and syphilis in 15 to 49-year-olds. So you can see from the chart on the right-hand side, the incidence is much higher in the WHO African region. There's a similar story for viral STIs, 291 million women with human papillomavirus that causes cervical cancer, and 417 million people with herpes simplex virus 2. These are 2012 estimates. Again, the prevalence of HSV2 was highest in the African region. As you all know, STIs have a profound impact on the lives and health of children, adolescents, and adults. Fetal and neonatal deaths, infertility. STIs are one of the major causes of infertility, and they're precursors to cancer, particularly cervical cancer. The risk of HIV transmission in those who've got STIs is increased 2- or 3-fold, and we shouldn't underestimate the psychological and social consequences of having an STI. What's been very exciting in recent years has been the new WHO Global Health Strategy on STIs covering 2016 to 21. And the STI control approach has been framed using 3 frameworks. Firstly, universal health coverage, and particularly mentioned in SDG Goal 3.7, and drawing from lessons learned from HIV using a public health approach in terms of moving away from a clinical individual focus to population-based national plans for control. This also includes things like standardized protocols, decentralization, community participation, focus on equity, and services that are free or affordable. There's also a framework of having a continuum of services, again, something that we've learned from HIV, these frameworks will inform and support the reaching of the 2030 global targets for STI control. The continuum of services, starting from individuals to people getting tested, then enrolled in care, getting treatment, completing treatment, and getting cured, and continuing to access chronic care for incurable STIs. So I am sure most of you are going to be familiar with this continuum from the one that we have used for many years for HIV. The 5 pillars of the strategy are improving surveillance and data on prevalence, etiology, and resistance. And this pillar really lags behind in STIs compared to HIV, providing an essential package of high-impact interventions across the continuum of STIs management, and then planning and implementing approach for delivery of these interventions that are suitable for different populations and in different locations. And then access to and scaling up of innovations such as diagnostics, vaccines, microbicides, suppressive therapy, and health promotion methods. And finally, sustainable and innovative financing models. I'm going to touch on some examples of innovations in the first 4 categories. So let's talk about surveillance first. The WHO and CDC laid out an enhanced gonococcal antimicrobial surveillance program, or EGASP, in recognition of multi-drug resistant Neisseria gonorrhea infection serving as a major global health threat. There is extremely limited data from sub-Saharan Africa, but a recent publication from Uganda demonstrated that it was possible to implement a standardized, quality-assured EGASP program. The paper reported 458 isolates of gonorrhea, Neisseria gonorrhea, that were characterized using e-test with associated epidemiological surveillance data in a period of 1.5 years. This far exceeds the minimum WHO global GASP requirements that ask for 100 isolates per year per country to detect AMR or antimicrobial resistance levels with confidence. And as you can see, there was widespread ciprofloxacin resistance, but high susceptibility to both azithromycin and ceftriaxone. The other big player on the landscape is rapid diagnostic tests, or RDTs, and the move away from syndromic approaches to diagnostic approaches. We all recognize the issues with syndromic approaches, given that majority of the common STIs are asymptomatic. And there have been several point-of-care tests developed for syphilis. The performance is comparable to laboratory tests, but do not distinguish between past and present infection. However, the cost of over-treating biological false positives is considered acceptable to risk of non-treatment. A recent diagnostic test developed by ChemBio combines a recombinant antigen to treponema pallidum with synthetic antigens to non-treponema pallidum antigens, and allow distinguishing from biological false positives and distinguishing past from present infection, but potentially have lower sensitivity than the other diagnostic tests for syphilis. Another really exciting innovation is the combination of HIV and syphilis tests. And as you can see, there are now more and more tests in the pipeline, and really play an important role because it allows syphilis screening in antenatal care to be piggybacked on the very successful HIV screening in antenatal care as part of PMTCT program, and may enable syphilis testing to be more widely implemented. A recent publication in the Lancet Global Health showed that this was a cost-saving approach in countries with widely varying HIV and syphilis prevalence, namely a study done in South Africa, Kenya, Colombia, and the Ukraine. Is been demonstrated to be an acceptable and feasible strategy in antenatal care settings. Following on from the theme of diagnostic tests, there are again many rapid diagnostic tests now in the pipeline for gonorrhea, chlamydia, trichomoniasis, and human papillomavirus. For the latter, it could mean moving away from visual inspection using acetic acid to screening for HPV before moving on to more invasive measures. And this is a very exciting landscape to allow movement from syndromic approaches, which were put in place because of the lack of infrastructure to do diagnostic testing in low-income settings. I want to pick up on two tests. The Gene Expert platform, which tests for several STIs and can use multiple specimen types, including urine and genital swabs. As you will all be familiar with, because it's been used widely for TB, it's an automated closed system using modular, and the machines are modular, and the turnaround time for STIs is about 90 minutes, which make it somewhat challenging for it to be a point-of-care test. The Binks platform tests for gonorrhea and chlamydia and has potential for being a true point-of-care test. The turnaround time is 30 minutes. It has received FDA clearance, but there are no published evaluations in low-income countries. So when we think about moving away from syndromic approaches to diagnostic approaches, there's a lot happening on the landscape. Just need to be consider the following issues. Some of these tests have not been validated in different populations and may have different positive and negative predictive value. They still require a degree of infrastructure. Some of them require uninterrupted power supplies and can't be battery operated. There's also thinking through how these are going to be positioned, where they're going to be positioned, and who the suitable populations would be to test. The turnaround time for some of these tests preclude use as point of care tests, and the biggest barrier currently remains cost. These tests remain very cost prohibitive. I provided a couple of references if you want to have more detail on the landscape of diagnostics in STIs. It's a very exciting place to be right now. Another innovation that has come to the fore is guiding treatment based on resistance testing, particularly for Neisseria gonorrhea. A recent study published in Clinical Infectious Diseases demonstrated that sequencing of the gyrase A gene allowed for detection of a point mutation that was highly predictive of resistance to ciprofloxacin. Now, that's very important because if we could reuse ciprofloxacin, we could potentially avoid use of ceftriaxone, which is one of the last remaining antibiotics for multi-drug resistant gonorrheal infections. Obviously, this relies on a very specific resistance mutation being detected, which may not be applicable. That approach may not be applicable to other agents. The patients in this study were selected on the basis of a positive nucleic acid amplification test, and it certainly isn't anywhere being a near patient test at present, but it's a promising approach. And then turning on to vaccines, something that we are all talking about in the context of a COVID pandemic. The chlamydia adjuvanted vaccine CTH522 was trialed in a double-blind placebo-controlled phase 1 study, and it is the first in-human trial, and the vaccine was immunogenic and very well tolerated in volunteers. And then another interesting approach, a retrospective case control study in STI clinics in New Zealand, took 14,370 individuals and essentially who had been vaccinated for group B outer membrane vesicle meningococcal vaccine. And the vaccinated individuals were less likely to be cases, i.e. those with gonorrhea, than controls, those who had chlamydia only. And you can see the adjusted odds ratio for being a case, and the estimated vaccine effectiveness was 31%. Well, that's quite low. What it does do is provide a proof of principle for vaccines for Neisseria infections, both gonorrhea and meningococcal disease. The one other aspect that I want to kind of bring to the fore is it's not just about diagnostics. It's also about how we are going to integrate STI services and provide STI services to individuals. And the strategy recommends integrating STIs into broader HIV and SRH platforms. And one exciting innovation is the CHETSA trial. This is a cluster randomized trial being conducted in Zimbabwe that integrates both HIV services with SRH services and STI services, as well as general health. So what this trial is doing is providing HIV testing, treatment, monitoring, adherence support with contraception, menstrual hygiene products, condoms, risk reduction counseling, and general health counseling, integrated with unselected testing for gonorrhea, chlamydia, and trichomoniasis, with treatment going on site and incorporating partner notification. You can look up more details of this trial on the website listed there. Importantly, what this study also is doing is focusing on how services can be delivered and tailored to specific populations in specific settings. So this particular trial is targeted at youth aged 16 to 24-year-olds and delivering services in a non-clinic-based setting, i.e. in community-based settings in community halls. And what you can see is a picture there of a gene expert platform being delivered in the field using generators. process evaluation of the first process evaluation of gene expert using being done in the field is underway for this study. The final thing I want to touch on is behavioral interventions for sexually transmitted infections. And we have a long history of developing behavioral interventions for HIV. The one that I particularly want to pick up on, which is innovative, is how we use condoms. Now, we've been using condoms and talking about them for 3 or 4 decades, but what we haven't really thought about is how we interface behavioral interventions with the needs and views of clients. So what was done in the HIVSyphilis study was reconfiguration of condoms so that they were more attractive and user-friendly. You can see the national program condoms with the Big Panther pictures on them that are unappealing and and are not acceptable to the general population. But these condoms were designed to have flavor, texture, and color, and essentially bring in a message of not just safe sex, but actually pleasurable sex, and ensure that there was high quality in the condoms. So again, an example of an innovation to improve what is a very well-known protection method against STIs. So looking ahead, where are we at? Essentially, there is a very exciting strategy, I think, that draws from many lessons we can learn from HIV and enshrines a framework in frameworks such as universal health coverage, which are now being implemented and being talked about, and also the SDGs. Importantly, there is a big paradigm shift away from decades-old approaches that have been used for STI control. I want to end by saying that there is much to do. There is a lot of opportunities for biomedical implementation and behavioral research. And that's a very exciting time to be doing STIs. So I'd like to thank you and happy to take some questions. Thank you.